Good morning. My name is Tyler Sosik. I am a student registered nurse anesthetist at Kaiser University in the DNAP program there. Thank you for the opportunity to speak with you today. I'm here because I believe we have an avoidable patient safety gap in front of us. As anesthesia professionals, we work hard to protect the heart, lungs, airway, and hemodynamics of our patients, but there's one organ system that still falls unprotected in a standardized way, and that is the brain. My proposal is going to be fairly straightforward. I'm asking for the organization that I'm presenting to today to adopt a formal perioperative brain health and delirium prevention policy for older and high-risk surgical patients. This matters because postoperative delirium is not a minor inconvenience and is not simply confusion after surgery. It is a real perioperative complication that affects recovery, prolongs hospitalization, increases distress for families, and exposes the organization to downstream costs and operational burdens. What I want from you to hear today, if we predict risk, recognize harm early, and implement evidence-based prevention steps, we should not leave that work to individual preference. We should standardize it instead. That is why this proposal matters to me, and this is why I'm asking for you to support this proposal. Slide 2. Here is why this issue deserves policy-level attention now. First, the population that we care for is currently changing. Older adults account for a large share of surgical volume, and that proportion will only continue to rise. That means perioperative brain health is not a niche issue. It is becoming a core business for every hospital and every surgery center that operates. Second, postoperative delirium is fairly common. In high-risk older adults, the incidence can be strikingly high. When delirium does occur, the consequences are not limited to temporary changes in behavior. We see longer lengths of stays, more complicated recoveries, greater morbidities, greater mortalities, delays in disposition, and very real suffering on behalf of patients and their families. The third point that I want to make on this slide is that the problem is very expensive. Delirium carries substantial healthcare costs, but financial impact is only part of the story. Delirium also consumes nursing time and resources, complicates pain management, increases safety surveillance requirements, and can undermine family confidence and the quality of care their loved ones are receiving. So that is the urgency that we're facing. There are common harms, visible harms, and very expensive harm. If we wait for every clinician to manage it differently, we keep getting inconsistent results. Healthcare does not need another awareness campaign. It needs standardized policies that make good practice reliable. Slide 3. This is my policy proposal, and the policy I am proposing creates a standardized pathway across the perioperative continuum. Preoperatively, we could identify risk instead of discovering it too late. That means cognitive screens such as the mini-cog or an equivalent tool, like a documented delirium risk flag in the anesthesia assessment, and structured medication reviews along with family education are necessary. If a patient arrives with impaired baseline cognitive function, sensory deficits, or significant frailty, that information should shape the anesthetic plan from the get-go. Intraoperatively, the policy would support brain protective care. That includes age-adjusted anesthetic dosing, vigilant titration of anesthetic drugs, proactive hemodynamic management, and multimodal anesthesia with deliberate attention to potentially delirious-inducing medications, if at all feasible. The purpose is not to make care rigid, but rather to make key protective actions expected and visible. Post-operatively, we would stop treating delirium as something we notice only after it becomes severe. The policy requires structured screening in PACU and on transfers, early non-pharmacologic prevention measures such as orientation, sensory aids, sleep support, hydration, mobility, and rapid escalation when delirium is suspected. And this is an important point. I'm not asking to add random tasks. I'm asking to include standardized or to standardize a few actions that are likely to reduce avoidable harm. That is exactly what my policy proposal aims to do. Slide 4, change management. So a good policy on paper can still fail at the bedside, so implementation is really going to matter on this. I would lead this change using a classic change management approach. First, we would create urgency by evaluating and showing our own data. That includes older adult surgical volume, delirium-related events, falls, sitter use, discharge delays, and patient experience concerns. People and institutions change faster when they see the problem in their own environment, so generating awareness on this is very important. Second, we would build a coalition. This cannot belong to anesthesia solely. We need shared ownership from CRNAs, anesthesiologists, preoperative clinical staff, surgeons, PACU nurses, inpatient nurses, geriatrics and hospitalists, pharmacy, and informatics. Third, I would pilot and train. I would begin in 1 or 2 high-risk service lines, for example, orthopedics or vascular surgery. These areas, there's an obvious need and there's a large opportunity for measurable impact. We would pair the policy with scripts, EHR tools, education, and local on-unit champions. Fourth, we would show our short-term wins. If screening compliance improves, if delirium is detected earlier, if families are better prepared, and if operational outcomes trend in the right direction, that will build momentum and help practices stick. That is why I included the Cotter and Lewin models down here in the corner with the attached links. These are somewhat ancient models, but they're very useful in creating urgency, building coalitions, and then refreezing new workflows. And this can be applied to delirium and delirium prevention. That way, delirium prevention can become routine rather than optional. Slide 5. What do I need from you guys today? I'm asking for approval of a structured pilot, EHR support for screening and documentation, education time for effective teams, and visible governance through a quarterly dashboard. In return, I'm committing that we will report meaningful outcomes, screening completion, delirium screening compliance, documented postoperative delirium, operational outcomes such as length of stay and discharge delay, and the patient and family experiences. And to close on a personal note, the patients most vulnerable to postoperative delirium are often the same patients whose families trust us most deeply. That includes older adults who come to us for relief, function, and a safe recovery. When those patients leave the operating room with preventable brain-related harm, we should see that as a systemic failure on our part and not just mere bad luck. If postoperative brain injury is predictable, measurable, and partially preventable, then failing to standardize our response is a policy choice. I believe our organizations can do better, and I believe anesthesia should help lead that change. Thank you very much for your time.